Welcome, everybody, to the Intersection Podcast. I'm Anton Gunn, an independent advisor with extensive experience in community advocacy and healthcare leadership. The Intersection is a project of the Robert Wood Johnson Foundation. It's a space for advocacy and healthcare leaders to talk to each other and share about how they're trying to build anti-racist healthcare systems. You can find us online at meetattheintersection.org. Today on the Intersection Podcast, we're joined once again by experts from our event called It Takes Two to Make a Thing Go Right, where we focus on building trust. Recorded directly after a more formal discussion, this conversation dives deeper into building trust and relationships between community advocates and healthcare organizations. Listen in as Marshall Chen, Torian Easterling, Sinsi Hernández-Cancio, and Shari Suchoff reflect on questions submitted to them by the audience during our panel discussion. So what were your one or two biggest takeaways based upon what we all shared? And Marshall, I'll just kind of start with you.
Well, in some ways, the word the intersection is a good name for this overall effort, because I think we saw these themes of, I wouldn't say parallel, but like different streams that need to come together to work. To me, there are the issues of culture and anti-racism. There are the issues of specific skills and technical things that CBOs and health organizations can do to advance health equity. I want to build off the end of the conversation where you asked a question about structural racism and George Floyd and whatnot, and what do we need to move on. So I think some of it was that there was value in that the police brutality and those discussions raising issues of the system being the problem. I think the health equity field, for too many years, we have default had almost a blame the victim approach. What are the problems with this particular person or their families or communities that are leading to these health inequities, as opposed to, when we look at COVID inequities or police brutality, much more awareness of the role of structural racism, systems of oppression, how the system is set up in a way that makes it hard for a lot of people to succeed. It's a rigged game in many ways. The other part to it, though, is besides systems, to address something like structural racism, it's going to require the hard work of communication, relationship building, having the hard discussions about power and hierarchy and all. So in other words, you can't just say there's a technical problem. We're going to do this payment intervention. We're going to do this care intervention, or we'll do this partnership with the community. In fact, one of the themes was the parts of the communities take a long time. They need trust. And it's not just the community. Any discussion about equity, like even within a healthcare organization, involves these issues which maybe not be understood by some or else purposely suppressed. And so until we have the honest discussions about how then the structural racism, other systems of oppression manifests then in how the healthcare system is set up in a way to lead to the health inequities, we're not going to get there. Because a lot of the change work is going to be both structural at healthcare organizations and then relational with how we work with one another, how we treat one another, how we view one another.
What was really interesting to me is that in many ways, we're very much on the same page about what needs to happen. I think I identified two things, like a real hunger and thirst show me how to do it, like really concrete, what is the exact thing that I need to do? And then also questions about how is the power moving in this system, right? And power includes, especially in our system, resources, right? Money. And let's not forget, healthcare is the biggest sector of our economy, our biggest employer. Theoretically, there's a lot of money there. Money is power. So the question is, what can we do to break down silos so that we can work together towards a redistribution of power and resources? Now, that can sound really scary to people. I think that the communications piece of being able to explain how this is not about robbing Peter to pay Paul. This is really about being intentional about where you're directing the resources that you have. Employer. So like, how are you going to treat your employees? You have to buy a bunch of things. How are you going to source that? And then how are you going to be a truly trustworthy, collaborative partner expert? We incurred all of this educational debt. We're the experts. We have all these letters after our names. The experts are not us. The experts are the people, I'm the, individuals are the experts of their own bodies. And that's something that the healthcare system still doesn't seem to be able to grapple with. And communities are the experts on their communities and what it is that they need to be able to live healthy, full lives.
That's real. Thank you for sharing that. That whole point around expertise, that people being the experts of their own bodies. I'll never forget what my mom told me when she turned 65 and she had to find a new primary care physician. And she literally went through a process of asking every physician that she interviewed to roll up their sleeve. And I was confused. What are you doing, Mom? She says, well, I want to see who has a polio vaccine like I do. Because if you don't have one, then you haven't lived long enough to know what might be wrong with me. And so that was her context, is that she wanted a clinician who had some cultural connection and experience to her and her health, and knowing that people born in the 70s, it was gone, as we don't have that vaccine on our arm. It's a very interesting point. So Shari, I want to get your reflections around the conversation. What were your one or two takeaways?
The number of questions in the chat about how do you do it? What's the rule? What's the measures? Can you share the playbook? And, I think there's lots of lessons that we could share, but there's no formula for doing this work. And it's just a constant battle. I want to sound more positive than that. It's a constant effort that you need to be making. And it's about finding opportunities as they arise and making the most of them. I was not surprised. I mean, I think these are the questions that come up whenever these conversations are being had, is about how do you really do it? People want to know. And it's really just about building the momentum and building the networks and building the partnerships and making a commitment to continue to work at it. There's going to be setbacks and challenges, and new people are going to come in and you're going to have to start over on certain parts of it. But it's that commitment to just keep going and finding the opportunities and making the most of them as you go, which is not as easy of an answer as I think people are looking for.
Totally.
Well, if I can jump in on that point, all that you're saying, Shari, is true. But I also don't want us to miss the opportunity that, and I learned this from Marshall and the National Partnership have been working on things that are actionable, almost like to-do lists, like where do you start? And it's true that there's not a magic bullet, but there are things that we know about what are the steps to take to start yourself on the way, and what are the questions or the actions that need to be taken so that you disrupt the standard operating procedure of how things are done that have worked so badly for so many of us, right?
Yeah.
And we even have a tool on the National Partnership website for our health equity virtuous cycle. Like, what are at different points of developing policies or programs, and also in research, you need to stop and ask the right questions. There's more of interest and I think momentum around building those kind of tools that sure need to be tailored, but we are trying to take 20 years of experience and making it kind of like usable for people. And I didn't want us to lose that perspective.
Yeah, for sure. Thank you.
Torian, your takeaways.
It was a great conversation. I'm really honored to join all of you. I'm always heartened to hear progress and the changes and the work that has been done. Seems like we're moving forward. And I think that is something that I'm always excited about and continue to be inspired to be engaged in this work. And then there's all the questions that continue to come up. And just specifically, these questions about how much do we need to talk about this intersection of race and class and poverty? Are we talking about that enough? Talking about the lie and this moral reckoning, and Marshall was just talking about it. Are we facing enough to push people into their uncomfort zone, right? And that moral reckoning of, do I still believe in the lie that white people are more superior than Black folks? Or am I really trying to achieve this, quote unquote, as Baldwin wrestled with, this multiracial democracy? I don't know. And I don't know how we spend more time on that in a panel like this. But I think those are the questions that come up when we're engaged. And sort of the successes of this work, and we certainly want folks to understand that there is success and there's been progress. And for those who are in that spectrum at the other end, like they're just starting, we want them to start now. For those of us who are further along and feel like that they're hitting this wall, like, yeah, I'm talking to my CEO, I'm bringing in the right community-based organizations, but what more do I need to do? Because I'm not seeing it in my data. I'm not hitting those metrics as I should. And that's where we have to wrestle more with those questions.
Very good. Now, speaking of questions, we did get several questions. So I'm going to start with the one that I remember seeing the first, and it's probably more to Marshall. And the question was, can you give specific examples of data you collect from frontline folks? And how do you collect that data? What you need to be measuring and what do you need to be transforming to make it an anti-racist health system? So I'll just open it up to whoever wants to go first.
It's a really complicated question because I sort of read the different types of data in that question. As a whole, I think people have been not particularly satisfied with what's out there right now with equity metrics. That's a start. If we're thinking about broader community effects and broader social drivers of health, then you might think about of community-based metrics. So innovative things include days spent at school or days spent at work or high school graduation rates, for example, measuring the health of a community, or aren't necessarily going to be like these hard clinical outcomes, but things like trust or being heard, being respected, feeling that there's been discrimination and all. So there's sort of a variety of different data sources, which all are valuable. The other element to it, well, to inform then interventions beyond like in like a clinical data system, again, the critical role of talking with patients and communities and partnering with them to truly understand the lived experience and to truly understand what the likely drivers are of the inequities that are seen in the data. So that's a very complementary piece. And if you don't have that, I think you're really up a creek in terms of having a successful solution.
There is what people, especially wonks like us, commonly think about as the data, but we often undervalue qualitative data. And that's where developing partnerships in community so that you can actually hear the stories of what was that pathway towards trying to get health and why it didn't work. And that is much more demanding in the sense that you need to develop the trust. And then you need to actually have a conversation, not just ask people to check off a few things on a questionnaire. That is very much undervalued. Who is generating the evidence and how it's being generated really matters. And I think we can learn a lot about the experience with community-based participatory research and things of that nature. But at the end of the day, we need the stories to truly understand what are the barriers and how to develop a targeted universalist kind of approach to finding the barriers and addressing them. When it comes to advocacy, numbers are important, but that's not what's going to change people's minds or capture people's hearts, right?
Yeah, that's a great point, which kind of takes me to what a mentor said to me many, many years ago. He says, Anton, facts tell, but stories sell. And we have plenty of data that will tell us the facts around why we need to do this work. But sometimes the catalyst for people's transformation in the work really is tied back into a story that you can tell or helping people and giving people the spaces to tell their own stories. Here's a second question related to that point around data. There were two questions, really. They're both related to funding. So one question was broadly, how can we do this work with little to no funding? The second question is, how can funders support data infrastructure efforts to plan and develop a much needed bi-directional close-the-loop referral? What do you do when you don't have a budget to do this work? Any advice for people who might be in that circumstance?
Work with what you have and you look at what that is and you think creatively about how to best leverage it. I think we've seen the hospitals that we work with, which again are very under-resourced safety net hospitals, being really creative and committed to finding the opportunities to leverage the dollars they have, working to identify community-based organizations who could do trainings for staff, who can help identify new sources of workforce, looking at where we're buying things. We created across a number of the hospitals in Brooklyn, a list of the MWBE vendors that each of us is using, and we shared them with each other. We got guidance from another hospital further along in this work. Start with pizza. Have people come up with a list of the MWBE pizza places nearby and share it with the department so that they're not ordering from Domino's, but they're ordering from an MWBE. Just start small and build your way up. Find those opportunities, and those wins help you get to the bigger wins and make more progress.
That's fantastic, because honestly, And that's actually how you start building trust. Like if you think about it, do you value me enough to use what I can offer? And even if it's just offering pizza or offering a perspective or offering stories or offering a place for you to host your meetings and events, all of those things are great ways to start to build trust. Any other thoughts on that question?
I think when you think about it, the idea of equity or advancing health equity really is core to the mission of just about any type of job description in an organization, whether it's a health organization or a social service organization, CBO and all. And so to the extent then that the equity activity is really sort of seen not as like an add-on, but really part of the core mission, part of the core job. So something like quality, well, how can you do quality without equity, right? Or if the goals of CBOs are to improve community health, community well-being, well, how can you not do this type of healthcare equity type of partnership if that's the goal here? It's going to be the hustling in terms of like small grants and that kind of thing. The light on the horizon is that more and more so, some of the major funding streams are better aligning with what this core work is.
I definitely wanted to jump in. Our organization has been doing with Brooklyn Communities Collaborative. Quite often, we as organizations, we have deliverables that we have to meet. Whoever our principal is, we have to report up to the board. But we have to sometimes push back on creating those silos and saying, like, these are the things that our organization has achieved and committing to ways in which we're going to partner and to say that these are the things that we must do if we're going to do the equity work. And I think part of doing equity work is saying that we're not doing it by ourselves, right? We're not going to achieve equity unless we're partnering, unless we're collaborating. There have been a number of grants that Shari and I and her team have been working on, and we have failed on a lot of those grant applications, but we are staying, at the table, right? This isn't like, all right, we failed and let's go on and move to something else. But no, we're going to keep going and we're going to continue to try to achieve what we set out to achieve and creating these collaborations and really working with these partners. And I think it's making those type of commitments, right? And I, for one, really am a favor of social pacts that institutions and organizations abide by so that we can do the work together. And I think that's really important.
Very good. Meaty question. I'll preface it with that I'm in the South. I'm in South Carolina. We got people who want to do this work in Florida. We got people who want to do this work in Texas, people who want to do this work in the state of Alabama. And this question came in. These efforts can be particularly or especially difficult where local legislators are a major obstacle to allocating funding to updated systems and services. So how do you deal with the local politics that might be around continuing your work to build an anti-racist healthcare organization?
I love that question. One role that healthcare systems have that they don't leverage enough really is their role as advocates. I was talking a lot about how money is very much power, but there's also like this other kind of power, the political power that unfortunately in many communities, individuals and communities don't have a lot, but there are other entities that have a lot of of political power that can be sharing it and using it for the benefit of those that don't, right? So that was one of the learnings that we had very clearly, that leaders weren't necessarily thinking about things in that way. And we were encouraging them to do so.
Very good. Marshall, any thoughts?
Yeah, there was a survey from 2016 by Robert Wood Johnson Foundation, and about 2/3 of a national population here in the U.S. said that they believe that everyone should have a fair and just opportunity to health. The reality is that there are some parts of the country where it's a hard discussion right now still, like using the words like racism and all. Yet there is this belief across the spectrum that particular the idea of a fair opportunity generally is well received across the political spectrum. I think there were going to be ways to get at the ultimate aim that might not be as direct in terms of calling out things as they are, i.e. racism in particular. But, the reality is that is what can be done in terms of essentially getting to the same place, but using the language of opportunity, other language that will resonate with this 2/3 of the public.
Very good. Well, thank you for at least weighing in on that, because I know a lot of people are struggling and looking for unique ways to continue to move forward despite the external prevailing winds. This next question was really around, since they were following up to something you said about co-creating. Can you speak to co-creation and how to engage and include the communities in the health equity related processes developed by health systems. If you can think of three things that would define co-creation for some groups that they could do right now, Shari, Sinsi, what would you add to this context?
That's an excellent question, and I wish I had more time to really think through it. I was involved in a project by the National Academy of Medicine on how do you measure authentic, real community engagement? And very quickly, we came down to the issue of power. And it's not just real power, but also the appearance of power, right? One thing they can do is rather than expect people to come to you, you need to go to them. And you need to go to them on their schedule. And you need to make it easier for people whose job is not to be doing advocacy, whose job is whatever their job is and taking care of themselves and their families and their communities, making it, enabling that inclusion into the process. So part of it is going to them. Part of it is enabling that. And then I think part of it is also showing that you are actually taking the input and doing something with it. And that's where the true co-creation comes, because it's not just like, what do you think is wrong? But then it's like, help us think through solutions and not just do your little town hall and, in the community center and then go back to your high rise and say, okay, so I think I know what we need to do now. That's not going to work. Making sure that there is real collaboration and real engagement and real sharing of power is essential.
Very good. Shari, how about you?
I agree with that answer entirely. And I wanted to say before, I just wanted to get back to participatory action research and how important it's been in driving our process from a couple of different ways. One, it really brings the voice of the community into the forefront. When we started in 2016, we were focused on, okay, how are we going to improve these cardiovascular disease rates in a couple of key neighborhoods in Brooklyn? And what we heard was about all sorts of things. And it was about food and access to good jobs and transportation. And it was not the things that maybe people thought they were going to hear about, like, the third next best appointment time or whatever the things the health systems are tracking. It's the things that actually matter in people's lives. And so one, that bringing that conversation into the forefront, incredibly important. The second is we relied on student researchers. So we had high school students doing the research under the direction of local college students and grad students from MIT. The high school students doing this research in their own communities built in a level of accountability for the health systems and the people leading this research that really, I think, made the difference. Because when you have high school students standing up there at the end of their summer and telling you, here's all the things we learned from our communities, these are the things people want to see, and we're going to be watching you. That makes people act. And it has been the thread that has continued our work. And people, they can quote the high school student from 2016 and what they said, and it sticks with them in a way that makes it real and makes it actionable, and it keeps them coming back to continue to do it. It has to be real. You can't ask people what they want and then disappear and not do it. They're paying attention. People notice when you don't act on any of the things that they're saying. So co-creation means really co-creating and having an equal footing at the table, and you're really committed to doing the work, and you're showing that through your action.
I love that story about the high school students, which makes me think, Anton, we all really need the t-shirt that says facts tell and stories sell, right? That is gold.
Yes. Speaking of stories, this is a great segue. We have a couple minutes left, and I really want to close with this. What was your moment that got you into this work? If there was a time, your story, your experience that made you decide that this was going to be your contribution to transforming lives in the American healthcare system, I would love to hear your stories if there is one.
I first understood what health inequities were and racism in healthcare when I was like 4 years old, hearing stories from my dad, who was a doctor and who was training in Western Massachusetts, and the unbelievable stories of the racism that he continued to deal with. And over the years, continuing to hear his stories of the challenges he had trying to take care of his Puerto Rican patients. And then, I would say my own experiences and my kids' experiences, like things that happen over and over again, where the way that the healthcare system is systemically failing people, all of the expertise that we have from working in the space, that continues to reinforce why I keep doing what I'm doing. And that I've really found the place where whatever skills and passion I have are going to make a difference
I'll go next. On one hand, there's the easy professional example of like any person training in healthcare. Within the first week of training, you see the inequities just daily in the clinic and in hospitals that had a big effect on me and probably most trainees. Like since maybe the root cause more is personal, where third generation Chinese American, my grandparents that came over for economic reasons for a better life. My parents grew up in Boston's Chinatown. My dad's side was laundry, and my mom's side was noodles. They both come from big families. And we would go in every Saturday to Chinatown to see the extended family. Most of my aunts and uncles were very talented, hardworking people. And there clearly was this bamboo ceiling where they worked in laundries, right? And they had a lot of blue collar jobs, and they lived in an ethnic enclave because that was what was possible in that era. Yeah, I remember like as a little kid learning how to play poker from my uncles. And when they got a bad hand at cards, they would fold the hand and they'd say, well, I don't have a Chinaman's chance. And as I learned more about sort of that phrase and the history and all, and the discrimination against Chinese in America, got a better appreciation for the role of structural racism, inequities, and how this translates to health inequities. My family background Chinese American, but this really applies to minoritized populations across the board regarding how systems of oppression impact the life trajectories and health of people.
Thank you for sharing. Shari?
And I think fundamentally, right, everyone's a patient at some point in their life. Everyone experiences the healthcare system and realizes how vulnerable of an experience that can be. And even if you are well-resourced and well-educated, it is a very daunting, overwhelming system. And I think you very quickly realize how much help is needed and how important systems changes at so many levels. And then just professionally, I started my career in politics, working in the Senate during the Affordable Care Act, and sort of got a lot of exposure to lots of everyone, to everyone. Learned about so many of the issues. It was obviously a very polarizing time, and although now it seems like not that polarizing, but at the time it seemed super polarizing. And I was always sort of driven by how much agreement there is about what can happen and how many transformation concepts are sort of agreed to by everyone, but the noise is on the margins, and was really driven to try to find a way to work in those things that make sense and where there is broad agreement, because there's a ton of work to do there in the middle. I don't know if this work exactly counts as in the middle, but I was drawn to transformation efforts and work to make the systems make more sense.
Fantastic. Thank you for sharing. Torian?
Yeah, I'll take a different spin just a little bit, because I think similar to others, it sort of started in earlier and sort of personal and both professional. Certainly you don't always hear stories where you get very discouraged. And we talked a little bit about tension and like, all right, this isn't really for me. I got to figure something else out. About 4 years ago, right before the pandemic, I was already contemplating leaving the health department, and I had to leave quick enough because then COVID hit months later. I would say that moment was really defining for me in my career, because it really showed us the magic and the power of people. We saw unprecedented collaboration. We were having conversations that we just weren't having before. And whatever barriers that we created in our mind did not exist, or at least we gave that perception that we wanted to be innovative, that we wanted to stop death. And so we needed to pull out all punches and just put everything on the table. And that was really powerful for me, because I know that we can certainly do that during peacetime, right? I felt like if we could pull our heads out of the fog of war and say, what do we need to do now to stop death? We are seeing persistent disparities and inequities ongoing. Now that, that we're past this period of the COVID pandemic, what can we do now? And now we have something to point to in contemporary times to say that we can really do the unimaginable, that we can really close the gap. And we've seen that with something like vaccines. And so I think for me that was really powerful, to dig our heels further into the ground and to be relentless.
Well, thank you so very much for that. I'm going to share my moment, and it kind of takes us back to the beginning of where we started with the theme song that opened up this first intersection event. I'm a hip hop kid through and through, and hip hop is where I learned my value around justice and standing up for justice and standing up against things that were wrong. But my healthcare story really starts in a place of privilege. I am a military brat. My father was in the Navy. My grandfather was in the Army. My great-grandfather served in both world wars, and my mom was a public school teacher. So we had healthcare my entire life. I've never missed a doctor's appointment, never missed a dentist appointment, never really paid for a prescription drug. My mom had 4 kids and never spent a single dime to access healthcare. And then I go to college to play college football in the Southeastern Conference, one of the big SEC schools, and never once worried about a medical bill. I've had 2 MRIs in consecutive weeks, never worried about what they cost, never worried about prescription drug coverage, never worried about seeing a clinician in any way, shape, or form. But it wasn't until I finished school and I got my first job at a nonprofit, and my boss asked me to go knock on doors in a low-income public housing community to ask people about their experience with the local hospital or healthcare system. In that summer of 1996, I heard 400 different stories. And depending upon your race, your ethnicity, your gender identity, your income, or the language that you spoke, I heard a horror story from 400 different people. And what I despise more than anything else is the fact that my dad, my grandfather, my brother, and everybody I knew put on a uniform to fight for this country, to make it free, to make it better, and to learn. Just in one community, there were 400 different stories of people being locked out, shut out, priced out, and kept from accessing health and opportunity to live out their God-given potential. It made me angry. More specifically, it pissed me off to the highest of festivity. And here we are 30 years later, I'm still actively, aggressively doing this work and trying to make the world a better place. So thank you all for your role, your story, for your partnership. I want to thank all of you as guests for being here as a part of this conversation and hearing these perspectives. I want to thank you for listening to the Intersection Podcast. For more information on upcoming events and to join our mailing list, visit us online at meetattheintersection.org.